fearful should Americans be about the virus spreading in the United States?
That's the million-dollar question. At this point, it was pretty clear early on as the Ebola epidemic took hold that we were going to be seeing Ebola crossing our borders. Now, the big question that people should be asking ourselves, and the question I think that really comes out of what you just asked, is how likely are we to see transmission in the United States? And that's pretty low. The likelihood that somebody's actually going to spread Ebola from across in the United States to somebody else is I think really, really low. And in that respect, I think a lot of the fear here is unwarranted. And you've seen, all the cases that have come across, either they've come across in special incubation units specialized to transport people with a disease like this and have done relatively well in hospitals, or in that case, as we know with the patient Duncan in Dallas, insofar as he was able to have contact, the CDC has done a really good job contact tracing and quarantining those who would make contact. So I think the risk of transmission is really low, and therefore the risk of any sort of outbreak is also really low.
Yeah, Doctor, talk to me a little bit about that kind of contact tracing, because how do officials monitor people who may have come into either direct or indirect contact with Thomas Eric Duncan?
Yeah, so it's really painstaking work. It begins with interviewing the patient himself and understanding where the patient was over the period of time that patient could have been infected, and then doing the work of actually looking into the logistics of who could that person have been around. In the case of the patient Duncan, it's pretty clear that involved family and others in the vicinity where he lived. But that also could mean, thinking about people who may have been seated within, 4 to 5 feet on an airplane or in some circumstance, or could have potentially shared a car or anything like that. And so it's painstaking work, but it involves really doing the legwork of finding people who could have come in contact in the time where that patient was infectious, bringing them in, doing necessary medical tests, and then keeping them quarantined over 21 days just to make sure that they don't come down with with Ebola disease itself and potentially spread the disease elsewhere.
Yeah, and Doctor, one of the biggest sort of concerns for people reading about this, following the story, is that the experimental drug ZMapp has run out. That's according to some reports earlier this month as well. What does that mean for patients?
Well, at this point, it's really unclear because we don't actually know that ZMapp works. So when we talk about what works in medicine, really the question that we're asking is, do we have data that suggests that those who have taken the drug fare better than those who do not? And at this point, ZMapp is what we call an experimental drug because it's exactly that. We don't have the data to really say whether or not it works. So at this point, the first question is, does the thing work? We think it does off of just anecdotal evidence that those who have had the drug have done pretty well. And then the second question is, can we use the drug in a meaningful way to actually address the epidemic? And at this point, that's clearly no, because again, the drug has run out. We don't have the infrastructure to be able to produce it in any meaningful way. And at this point, the best thing we can do is really support patients who have Ebola until their body can fight off the infection itself. So all that is to say that it's potentially bad news, but to really say that it's bad news is it requires us to know that the drug works, and at this point, we don't.
Well, I've got a comment here, Doctor, from Gina, who says years of budget cuts to the CDC, NIH, and public health departments in Texas will make this a bigger problem than it turns out to be. That family that was trapped with contaminated material for 48 hours in Dallas is a classic example of, quote, this is the best we can. What do you make of that? Oh, Doctor, I think we may have lost.
Yeah, no.
There you go. There you are.
Yeah, I'm sorry. I heard the first bit of the comment. And just to speak to the potential limitations in health funding and the implications that have had, it's important to remember that public health works behind the scenes. Very rarely do we see the public health system working because, by definition, it's working when we don't see disease, and we don't realize how much the public health system actually protects us without us even knowing. And that really is the challenge. And so in that respect, when we put things on the political chopping block, it's pretty easy to take public health and put it earlier on in line because, again, we don't see it acting right in front of us until we have circumstances like this, where we have simultaneous epidemics of Ebola happening in West Africa, and then also a very concerning epidemic of enterovirus D68 right here in the United States. And in the setting where we've been cutting funding to important public institutions like the CDC and the NIH for some time, we now realize what the implications of that is, and that may be slower response, less capacity to move important research around, for example, an Ebola vaccine and or Ebola treatments forward. And that affects all of us, unfortunately.
Yeah, I hope, Gina, that answered some of your question. Dr. Fani, Rick Sacre, a patient who was obviously treated for Ebola, came down with a respiratory infection. I mean, is Ebola ever recurring?
So as far as we know, again, what we understand and know about Ebola is very limited insofar as, this is the worst ever outbreak. The previous several outbreaks, number one, the big ones took place in times where we weren't nearly as medically advanced. And so our understanding of the dynamics of the disease is limited. That said, from what we understand is that once an Ebola patient has had the disease and cleared it, the likelihood of that person getting Ebola is low. However, we need to take that in context because that's in a time of relatively low number of Ebola subtypes. And at this point, this epidemic has raged on to the point where there may have been meaningful evolution of different subtypes of the Ebola virus, and that itself may then potentially put patients who have had the virus at greater risk. However, at this point, the going knowledge, our understanding suggests that once you've had Ebola and cleared it, you're now immune because your body's built up the necessary antibodies to be able to fight a future infection if it were to happen.
And the US is obviously considering more stringent screenings at domestic airports. What exactly would those entail?
It would generally entail trying to look for evidence of potential disease in patients who are coming from those countries or have had a recent travel history within the last 3 weeks to those countries where the disease has become epidemic. The problem with that approach, however, is that the first symptoms of Ebola are really nonspecific to Ebola. These are things like fever, aches and pains, sore throat, runny nose. And we know that these are the kinds of symptoms that you see with any disease. And so if the goal is to pick out the disease early on, it's really almost impossible to differentiate Ebola from any other disease. And so it's not a very specific approach. The other problem is that it's not also very sensitive insofar as we know that the incubation period for Ebola is up to 21 days. And so those patients who could potentially be bringing Ebola across our borders actually aren't necessarily showing symptoms earlier on, even though they could develop symptoms 21 days out. And so in that respect, it's an idea, and it certainly might serve to quell some of the public fear about the epidemic. But to think that from a public health perspective, it's actually going to work very well, that's likely not true.